If you happen to stumble upon this video, my name is Mike Putoff. I'm a professor in the physical therapy department at St. Ambrose University. If you're one of my students, you know who I am. This is a case example of a patient in the intensive care unit that we're talking about in class. Students, you should be following along with your handout that goes along with this case as we go through this. If you did happen to stumble upon this and you want to see the case that goes along with this, I'll put a URL to a shared Google Doc where you can download the document and then follow along. The URL, I also put this in the comments section below so you can click it. So you should have the case in front of you. As you see, this was a patient who is in the respiratory ICU, came in with respiratory failure, kind of declined as he went, came to the hospital. They tried to keep him off the mechanical ventilator using a high flow nasal cannula, also BiPAP. That didn't work. Ended up putting him on the mechanical ventilator with assist control pressure. FiO2 is at 70%. His PEEP was at 5. He was fighting the ventilator. They put him on different medications to help sedate him. The next day, they did put him on a sedation vacation, as you see in your handout. He was able to breathe spontaneously on his own. His RAS score was +1 and a negative CAM ICU. So all good indicators that this patient was appropriate to begin mobilization with. So what does this information tell you? Well, first off, like I just said, that this patient's appropriate for mobilization. So keep that in your mind. But also you look at this and you see this patient had a long-standing history of pulmonary disease, but had exacerbation of his issues because of an infection led to respiratory failure and required mechanical ventilation. If you look at some of the indicators, he is showing some signs that he's appropriate for physical therapy at this time, or at least to be evaluated and considered that way. Question on your handout says, keeping the A, B, C, D, E, F bundle in mind, what further information would you seek out about this patient? Well, we already know, if you see on the screen, that you have the A, B, C, D, E, F bundle. We know that his pain levels are 3 out of 10, so he's doing okay. He responded well to the spontaneous breathing and awakening trial. His anesthesia and sedation seem to be correct or at the proper dosage given his response, given his alertness. Delirium is negative. Also, his RAS score is good, showing he's alert and likely able to participate in therapy. If we look at the E, we're getting ready to do some mobilization, some exercise with him to see how he responds. And the F is the unknown. We don't have a lot of information right now about his family, his wishes, and his support system. So the big thing right now is finding out more information about his family as we jump into things. But if we look at the A, B, C, D, E, F bundle, he appears to be doing everything right or in a good situation to start therapy. The next question in your handout deals with what information would you like to get from the nursing and respiratory therapist? And I think this is your basic information. How's the patient feeling today? How's he responding? Anything you should be aware of? Any changes in medications? We mentioned before the F, the family. Has family been around? Has family had a chance to visit with him? As you begin to start thinking about mobilization, you should be checking with the nurse and the respiratory therapist to see if they're available. Can they come in? Can they help you manage the lines, the ventilator? Can they be part of the interprofessional team that will focus on mobilization? Now let's go ahead on to part 2 of the case. So in this part of the case, you're getting more information about medical and the social history. So go ahead, take a few minutes and look that over. Okay, now that you looked at the second part of the case, the question is, how will the patient's medical status and past medical history influence your management? Well, we see that he has had a history of COPD and he's had other bouts of respiratory problems that have required hospitalization recently. So this is not his first trip to the hospital. We look at his past medical history. He has diabetes, hypertension, AFib, heart failure. So we might be thinking when we look at the EKG, there might be some arrhythmias. There may be some AFib. We might see widened QRS because of his heart failure. We might see an irregular rhythm. So just some things to be aware of. We also know he has osteoporosis. He's had some issues in his thoracic spine. So we want to keep that in mind just as we mobilize the patient. It's probably not going to impact us too much in what we do, but we want to keep those things in mind as we mobilize them. The next question asks, what do the ventilator settings tell us? And we see that he is now on pressure-regulated volume control. And if you remember how this works, it uses the smallest amount of pressure possible to deliver a set volume. Now, we don't know what the volume is, but it's a good sign he's on PRVC, as opposed to before he was on an assist control setting where the machine was doing pretty much all the work and he wasn't moving very well. So it's a good sign he's on PRVC. His breaths per minute is set at 10, meaning the ventilator is going to do 10 breaths for him, but he can take more breaths and get assistance from that as needed. Another good sign is that FiO2 is now down to 40%, and we'll talk about later about mobilization decisions. But remember, if he's above 60% FiO2, in many ICUs, that's a point to stop and pause and really say, do we want to be mobilizing this patient? So we're optimistic by seeing these ventilatory settings. The next question is medication. If you look at his medication, we won't go through each one of those, but you see his medications match up to his past medical history. So some for his hypertension, some for his heart failure, also some long-acting and some short-acting medications to help with airflow, and also some medications to help with inflammation. So it's good to see he's on these medications, but it also tells us that he's at a later phase of his COPD if he requires all these medications. Okay, so if we look a little further at the next question, this deals with other information we might want to get from the patient. So if we look through this, a few things to point out is that we do have information on his social history. So we see that his wife and adult daughter lives with them along with grandchildren. He can do stairs. He has to rest a little bit, so get some shortness of breath with that. Also, he's able to be out in the community as a tour guide. He has a cane that he uses. That's all important stuff to be thinking about from that standpoint. Other information, again, you see what his pain level's at, as you got that information from him. His vital signs appear to be pretty good based on the chart review. This isn't a direct measure right now, but from 2 hours ago, it looks good. ABGs are starting to look better, right? So if we look back in the first part of the case, we saw his ABGs did not look very good. And if we look at a lot of his lab values, we should look at that and say, yeah, they look good. They're safe for mobilization. Some could be a little higher, a little bit better, but he's safe to be mobilized. So the next question asks you to go to the consensus statement on safety criteria for active mobilization in ICU. You can see the link to the article right there, and this is an open source article or consensus statement. So go ahead and take a look at that and open that up on a different screen. So as you look at that document, remember this was a group of experts who got together and said, these would be some considerations we think about or consider when we're mobilizing a patient. So if we look at the green dots, obviously mean it's safe. The yellow dots means, or the yellow triangles mean some caution. The red stop signs mean stop. And I'll let you look at those. If we look at these, our patient has an endotracheal tube, no problem with that. His FiO2 is below 0.6. Saturations are sitting well for nursing notes, respiratory sitting well. His mode is okay on the ventilator. PEEP is in a good situation, and he doesn't have anything else with respiratory that would make me be concerned about mobilizing. If we look at the issues of cardiac issues, we see no medications to keep his blood pressure up. Based on what we know so far, his blood pressure looks okay. We have not seen an EKG yet, but there's nothing in the chart that would indicate any cardiac arrhythmias that are major enough to change what we do. Heart rate seemed to be stable. No ECMO, no femoral line, no LVAD or VAD, no pulmonary catheterization done, and no known DPT or anything along that line. So from that standpoint, he looks okay. The neurological conditions, again, our RASs are right where we want it to be. Delirium was negative, so that's a good sign. No intracranial pressure monitoring and no open drain or any other kind of neurological issues. And then finally, we look at surgical issues. Again, he did not have surgery, so that's a good sign. There's no indication of active bleeding or a temperature. He might have some weakness or might eventually have some weakness we should be aware of. But again, that doesn't limit it. And there's nothing else that limits him. He has some other drains and attachments on this list, but nothing that's going to make us not mobilize him. So based on what we know about this patient and looking at the consensus, this patient's okay to continue with. So the next question is, what type of test and measures would you want to complete on this patient? And we won't go through every single test and measure, but the big ones, of course, are going to be strength. We want to look at mobility in bed. We want to look at balance. If we stand up, we want to look at gait. We look at transfers. Of course, we want to look at pain, his response to activities. Those are the big things from that standpoint. We have to be thinking about function, making that a top priority in what we're assessing. Also understanding if he has enough capacity to go from one progressive mobilization step to the next. And you can look at some of those models that we talked about in class, the PERM progression, where you first look at to see what's the leg strength, and then if it's okay, you sit them up and progress along that lines. But that's what we're looking for, is some decision making from that standpoint. And I'll show you some test and measures from this patient coming up real soon. We're on to part 3. And this is going to be more looking at the monitors and helping making some decisions on your patient. So based on your chart review, you decide the patient is appropriate for therapy assessment. From the nurse's station, you see this screen going on over here that we're recording. So you look at that. How do you feel about these vital signs? Hopefully you look at this and say, yeah, this patient looks pretty good. Good heart rate, good blood pressure. Notice there's an art line in. Respiratory rate looks good. SpO2 looks good. We should feel very good about entering the room and starting to work with this patient. Okay, so now you go to the patient's room, you knock on the door, you say, hello, Mr. Smith, this is Mike, I'm your physical therapist. We're gonna get you up and see how you feel today. And you notice these changes on the monitor. Okay, heart rate goes up, blood pressure rate goes up, respiratory rate might go up a little bit, who knows, but what's your first response? Oh my gosh, what did I do, right? This patient's probably a little nervous, hasn't been out of bed yet. Maybe they have experience with physical therapy, maybe not. Probably some nerves going on. So you just need to calm the patient down a little bit, work through things, make them feel comfortable with you. Okay, so now you are at the point that you calm down your patient a little bit. You did your subjective, nothing earth-shattering, kind of compile or matches up the other things we talked about already that are in the case. But now you decide to start collecting some information, doing your assessment. What areas do you want to assess? Well, I asked you earlier to think about those things. And let's say you get these results. You do a integument examination, or at least a screen. You'll notice redness on the buttocks, skin's intact, some swelling in his ankles, and this matches up. Think about your clinical reasoning process. This matches up with someone who's bedbound or who's in the ICU, and it's some indicators that we probably need to get this patient up. Range of motion, there's some loss of dorsiflexion in the bilateral ankles. Now, is this long-standing? Is this new? We don't know. Strength, we do some assessment of strength of the patient, and we see he does have some weakness in his legs. Maybe we're thinking, okay, is this patient going to be able to stand for us? How's he going to tolerate this? Thinking maybe some ICU acquired weakness, but we're also thinking that this patient came in with a history of COPD, previous hospitalization, so maybe he probably wasn't 5 out of 5 for many of these muscle groups, but he's probably lost something as his time in the hospital has gone on. So now we go on, we look at bed mobility. We start to roll him. He requires min assist of 1 to roll in bed. And this is how we're assessing his skin. We're protecting his ventilator tubes, and we see this on the EKG. And you look at that and give you just a second to look at that. Normal heart rate response, blood pressure's up a little bit. Notice this is a little bit lower than it was when you first walk in the room, but higher than it was when you were at the nurse's station. SpO2 dropped a little bit. You're always checking the finger probe. Did it come loose a little bit? Is it a good enough reading? But either way, we feel pretty good about that rolling in bed. So he tolerated rolling okay in bed, and now you've decided to go from supine to sit. So you're going to work with him there. Let's say he needs mod assist of 1 to get to the edge of the bed. There's another therapist in there with you, or even the respiratory therapist with you, who is protecting the lines and the tubes for you. Okay, so you get him up on the edge of the bed, and then we see these monitor readings. Okay, so now we have this patient sitting up on the edge of the bed, and this is what you see. You see his heart rate's gone up a little bit. You're seeing kind of a irregular rhythm, just a sinus arrhythmia. Every once in a while, you're seeing a pause. Blood pressure went up like we'd expect it to. Respiratory rate went up like we'd expect it to. But his SpO2 has dropped below 90 and below 88. So that might be a little bit of a concern for us. So think about what your action might be here. Well, you have a couple different choices. One, you could lay him back down, decrease the oxygen demand in the body. Number two, you could encourage him to take some nice deep breaths, calm down a little bit, see if that brings it up. Maybe he's holding his breath, maybe he's fighting the ventilator, maybe he's really stiff in his trunk and in an isometric contraction. Or number three, remember, we can give the patient an oxygen boost to try to bring that value up a little bit, to give him just a short 2-minute burst of 100% O2, which will help with his breathing. And let's say you encourage him to take some nice breaths with the ventilator. Let's say he was fighting the ventilator a little bit, really tense. You calm him down a little bit, and his SpO2 comes up, respiratory rate drops a little bit, heart rate drops a little bit. So you didn't necessarily need to give him an oxygen boost, let's say, but let's say you just need to let him adapt to being in that upright position. So now that he's on the edge of the bed, his vital signs have stabilized. You feel pretty good about that. You're thinking, okay, what are my next steps? Well, this is a chance to go through and auscultate his lungs as he's sitting up. It's a chance to look at his posture a little bit, look at his sitting balance. So let's think about those and see what we got from those results. So we look at his auscultation findings. He has some crackles on auscultation, bilaterally, consistent with being in bed, not moving around. We're thinking about his heart failure a little bit and being concerned about that. Some wheezing heard during expiration. So we're thinking about secretion buildup. Again, thinking about what are we going to do to get those secretions out? Will we have to suction him later? What's going to happen from that standpoint? Once he's off the ventilator, we'll have to work to get those secretions up through some of our airway clearance techniques. Good that there's no abnormal heart sounds. He can maintain good sitting balance, as you can see. He loses his balance when he reaches, but we're thinking okay with that. And his posture, while not perfect by any means, this is not surprising based on the patient that we can think it might be ahead, right before us. So now we're thinking, edge of bed, we have some good examination results. Are we ready to try to stand with this patient? Well, hopefully you would stand this patient up. Vital signs are looking good. His strength in his legs was a little bit lower, but it doesn't mean we can't try to stand him and see how he does. So I would encourage you to try to stand him up, see what happens, be ready with an extra person to support him, make sure someone's there to protect his lines and tubes, and let's put him into standing and see what happens. Okay, you stand him up. He requires max assist of 1 to stand, a second person to protect the lines and tubes. He does have a front-wheeled walker to support himself with. He is able to support himself with mid-assist from you to hold him up. But let's look at the monitor, which you see on your screen. What are you thinking? Well, let's start from the top. EKG, the pattern looks okay. He's still in sinus rhythm. Occasionally we see some pauses, but he definitely is in tachycardia. One situation we didn't talk about earlier was what's the upper limit for heart rate for this patient? Well, we think about 60 to 70% of his heart rate reserve. Other guideline standards might say 120, 130, in that ballpark there. So he's not near that. Okay, so he's safe in his heart rate. His blood pressure, though, what happened there? Well, his blood pressure dropped. So that's a little bit of a concern too, right? His blood pressure is down a little bit. He has the art line in. Of course, we want to check to make sure the transducer is at the right level and that we're getting a true measurement of what we're doing. Respiratory rate's up. That by itself is not too concerning. SpO2 is down. Again, he's still above 90, flirts a little bit with 89, 88, but he's doing okay. So what's your action at this point? Well, you might just stop for a minute, look at the patient, see how he's responding. If this is your immediate reaction, I may not sit him down right away, but I'm watching that blood pressure. Was this just a blurb that his blood pressure is remaining this low? Again, double checking the transducer. What does he look like? If he maintains at this blood pressure as a little bit lower and it's not coming up and he's looking a little bit bad, I'm going to sit him back down because I feel pretty good about the accuracy of that arterial blood pressure or the arterial transducer to measure his blood pressure. So let's look at a few other arrhythmias or changes in the monitor that might make us react differently. Okay, if we saw something like this, where we're also seeing PVCs on our EKG, that might be a little bit more concerning. If we did not have PVCs earlier, but now we're getting PVCs, a little bit more concerned about that. Now, of course, if his baseline was having PVCs and that didn't change, we're less concerned, but it's the change where there wasn't PVCs and now there are. Okay, so let's look at a couple of different things. Of course, if it's more Multifocal, we're a little bit more worried about that. So if we're looking at this and monitor usually takes a minute or two to respond. Seeing one PVC like that, one like that. There we go. So different shapes of PVCs, we're a little bit more concerned about that. That would make us probably stop what we're doing. Let's go back and look at something a little different. Let's say, again, we ran through pulse oximetry, and let's say now our pulse oximetry drops in standing. Okay, so we're down to 84, something pretty low. Again, we're going to check the probe to make sure it's on the patient correctly. But this might be a situation where we need to give the patient an oxygen boost. Can they keep standing like this? If you give them some time to quickly respond, if they keep at this level, I might sit them down though. So if they're at this level, look like you might be able to give them an oxygen boost, get that number up a little bit, and they respond, sure, keep standing. Okay, but if they're not responding, they're still in this mid-80 zone, you probably want to sit back down and reassess the patient, see how he's doing, and make some decisions from there. Earlier, we ran through some blood pressure changes we're aware of. The other blood pressure one, I guess, is if it goes really high. Okay, so we're concerned about really high blood pressures. Remember, we want to think about keeping the blood pressure a little bit lower, the mean arterial pressure around that 110 or under 110. So we're not quite there yet, right? And 160 is not outrageous, but if it's a big jump in blood pressure, he was at 120 before, jumped up to 160. Keep monitoring, keep watching him, see how he's doing. Of course, if it gets up to those upper levels of 180, 200, that's definitely a reason to stop what we're doing. So we ran you through a few monitor changes we want to be aware of, but let's show you kind of a normal response. So I'll show you a normal response, and then let's talk about what we might do next. So here we go. He's in standing, heart rate's still a little elevated, blood pressure came up, but normal response, respiratory rate's a little high, SpO2's okay. So you'd look at this and say, okay, we can work with this patient, we can see how they're doing. So now we have him in standing. He's still standing in front of the bed. What do we want to do next? Well, before we take off walking, we really want to assess safety to make sure it's safe to leave the bed. So remember the egress test. We might have him march in place a couple times. We might have him do a mini squat to make sure he's okay. We might have him take a step forward and then take a step back to make sure he's safe and it's okay for us to get away from the bed. Okay, so let's say he's able to shift weight. He can lift a foot up. He can do it 2 times in each foot. He can take a step forward with 1 foot, but he needs some assistance to get that foot back to neutral. And then we try to do a mini squat with him. He bends his knees. He can't get back up into that standing position, and it takes max assist from the therapist to bring him back up into standing. So what's your next action? Well, likely he's might be a little rattled from having to need that assistance to sit or stand back up as his knees gave out on him a little bit or he couldn't get back up. It might be good to sit him back down, let him rest, see how he's feeling, look at your vital signs. You might want to stand up again and try the mini squat again or just see how he's doing in standing. You might want to stop your interventions at this level and have him stand up or stop your assessment. Have him stand up and then do interventions in standing in front of the bed. I would be a little cautious of having him take steps to a chair to get into the chair at this point, given that his knees went out on him. Now, of course, if you stood him up and he did okay, that second time around, then maybe you could think about going to the chair. Okay, so you're trying to make some decisions at this point based on the response, based on safety, what's the best thing to do for this patient. So let's assume for this patient, we did the standing, we did not get him into the chair, we put him back into bed because of our concerns about leg weakness. And there's a couple different ways we can rate his mobility. We can just go through and describe it in our chart, say sit to stand, standing balance, etc. But there are some nice mobility scales that have been developed in the ICU. So if we look at a couple of them, one would be the functional status score in the ICU or FSS-ICU. If we scored our patient on this, look at rolling, he required mid assist for rolling, supine to sit, he required mod assist, unsupported sitting, he did fine, he required supervision once he got there. Ambulation category, sit to stand, max assist, and he did not ambulate. So it puts us at a 14. We can set some goals based on this and looking at the score. So hopefully we get him to the point that he could do his supine to sit, maybe with just supervision, get him to ambulate a little bit, increase his strength with the sit to stand. That can help us in our goal writing. The other is the Chelsea Critical Care Physical Assessment Tool. This one, you see the score, he had a 19 out of 50. Again, we can use this to set some goals. This is a spider graph, and we can look at this quickly and see that, okay, he did, along this 2 to 3 zone for strength and respiration, that sort of thing. But really, there's this big bite out of the graph over here telling us it's his higher level. Sit to stand, transfer, stepping. Those are the things he's having more trouble with. Outcome measure would be the PERM ICU mobility scale. So we look at this and we can go through, and we won't go through category by category, but you can look and see, okay, gave him a 2 for awake. He could follow some commands. Was he mechanically ventilated? Yes. Did he have some tubes in? Yes. So we got a 0 there. No drips. We looked at leg strength, arm strength, bed mobility. We see he required mod assist and then also required max assist for the sitting balance. Min assist or supervision for sitting balance. Standing, we see he got 0 points for gait and 0 for endurance. The nice thing about this scale is you see it has some room for improvement, whereas the FSS ICU and the Chelsea don't get into maybe the endurance like this one does. So you'll have some patients that are gonna walk with min assist, do really well, and they can only walk 50 feet, while another might walk more than 100 feet. This outcome measure gives you a little bit more leeway to capture those things. And then the other question in your handout talks about rating this patient on the ICU mobility scale. And if you remember from lecture, this is something that may be used to communicate mobility across the whole interprofessional team. So if you look at this patient, where would you put him at? Well, I'd say maybe a 4. The patient can stand, he can do some standing, but he's not able to transfer to the bed yet. So the next session you might come in and you might change this scoring so the rest of the interprofessional team understands what the patient's at. If you go back and look through your handout, the one question we didn't answer is how would you end this session? So think about that a little bit. How would you end this session? Well, you'd probably recap with the patient what went well, tell the patient what you're going to work on next session, really build that confidence of the patient, because it can be scary to get up and move when you're mechanically ventilated and you have all these things going on in your system. Okay, so think about that. Of course, you want to get the patient comfortable, positioned, call light within reach, make sure pain is okay, make sure the patient's respiratory status is okay, and really just make sure the patient's safe to be left alone. Okay, let's bring this case to conclusion. So hopefully through this case, you saw how we can use a progressive mobility actions to decide when to mobilize the patient. You saw how we use the vital signs, the results of the EKG, blood pressure, SpO2, and some of the actions that we might take. Now, if we think back to what I showed you on the EKG monitor, there's lots of different ways we could have gone or debate back and forth what we're going to do. It's always really difficult to make those decisions in class unless the patient's right there in front of you, right? So those monitors are very important, but don't forget to look at the patient, see how the patient's feeling, see how the patient's reacting, and that's going to be just as important as what an EKG tells you. So if you're a St. Ambrose student, you should look at the rest of this packet and look at the assignments for Blackboard. You're going to go through and talk about some activity limitations, participation restrictions, thinking about the ICF motto. You're going to set some goals for this patient, write a diagnosis for this patient, and set your plan of care. And then you're also going to write a PICO question surrounding this patient and post that on Blackboard and comment on your classmates. Those of you who are not St. Ambrose students, good job hanging in there the whole time. Hope I didn't put you to sleep. If you have questions, you can contact me at my email address. Have a great day.